Welcome, everyone. We're very pleased to have you all. I think I'm off. We would ask that people answer the poll as we give everybody a minute or two to get started and feed into our presentation here. Thank you all for joining us. We're slowly feeding in the number of participants. In the meantime, please, like I said, answer the poll question. And if you have a chance, please, we would love to have you start putting information or putting comments into the chat as well, just so we can start that up. So if you can put your organization, where you come from, into the chat, that will help us to get started and know a little bit about who all is listening in on this presentation. Like I said, we're going to give everybody just another couple of minutes to come on in to our presentation, Organizational Ethics in Healthcare. What is it? Why does it matter? Why now? So welcome, everybody. Let me just give it another 30 seconds. Oh, there we go. Now our chat is getting nice and full. Excellent. That means people can hear us. They can see. It sounds like we've got a whole range of organizations, healthcare organizations, and a range of different places. So this is very exciting. I'd love to go ahead and close the first poll, Michael, and if you can put the summary up, and I will go ahead and get us started. Well, I know that we'll have more and more people who will be joining us in the next couple of minutes. So thank you all for joining us for this presentation, Organizational Ethics in Healthcare. What is it? What is it? Why does it matter? Why now? This is a presentation that came out of the American Society for Bioethics and Humanities Organizational Ethics Affinity group. And we have met for the last many, many years. It's been a long-standing affinity group in ASBH, but it's been an opportune time, given everything that's been happening in the last couple of years with COVID and so on, to really try and reinvigorate and think outside of just meeting and knowing people at the meeting. So after having a small subgroup meet up, we thought that it would be time to bring the group together and really start at the basics of what is organizational ethics, why does it matter? So let me do a little bit of housekeeping and then I'll introduce myself. And like I said, if you can continue to put into the chat your organizations as people feed in, we would definitely appreciate it. So what we're going to do while we're doing the presentation and while our speakers are speaking, we would ask if you have questions directly for the speakers, if you could speak to them, post those questions in the Q&A section. That way we can identify them from the long string of conversation. If you have comments on what is being said, we definitely will be reviewing the comments. But if you want a direct speaker response, we'd ask you put that directly into the Q&A section. Just to introduce myself, my name is Melissa Bottrell. I am the co-chair with Matt Winia of the OEAG. I work currently for Active Resources, which is a government consulting firm, and I also work with Ethics Quality Consulting, which is my small consulting business on my own. Just by background, I have spent most of my career focused in organizational ethics, first in academia, working on research projects such as appropriate transfer of patients from nursing homes to hospitals at the end of life and the sort of policy questions that are imbued in that. Then in government, as one of the core developers of the VA Integrated Ethics Program that connected ethical thinking into all aspects of health program governance. And then now in my private consulting, I support ethics programs in hospitals, public health departments to develop and execute well-designed hospital and clinical and organizational ethics committees. I'd also just like to introduce my co-chair, Matt Winia, who cannot be here at the start of this presentation because he's actually giving a presentation on his own, but he'll be joining us at the end. But my co-chair for the ASBH-OEAG, is Matt Winia. He has led the Institute for Ethics at the American Medical Association for 15 years and co-founded its Center for Patient Safety before he moved in 2015 to become the director of the University of Colorado's Center for Bioethics and Humanities. The Center for Bioethics and Humanities is involved in the education for every health profession student at CU. They facilitate clinical ethics case consultations for hospitals on the Anschutz Medical Campus, and they carry out a research agenda to better understand the complex ethical challenges that face medicine and society. The center also runs the Aspen Annual Ethics Leadership Program, which is a great program, and several major community engagement programs. He's led national projects on issues including public health and disaster ethics, ethics and quality improvement, communication, team-based care, and a whole range of other things. He's a fellow of the Hastings Center, past president of the American Society for Bioethics and Humanities, and a host of other roles so central to organizational ethics. We really do appreciate that all of you have joined us here today, 58 and counting, and I know I've received many messages from today from people who want to listen in, but have conflicts, so we'll be listening in our virtual recording afterwards, which is also exciting. As I said at the top, our effort grew out of discussions where we wanted to further the reach of and the conversation around what is organizational ethics in the American Society for Bioethics and Humanities. I think us organizational ethicists sometimes feel that we're on the side with the clinical ethics getting all of the focus, but we know, and we've seen with, certainly we've seen with COVID, those key organizational ethics topics are really front and center, and those are not the only ones. They are massive and feed throughout the healthcare system. So we did a survey early in 2020 about what the OEAG members thought the scope of the OEAG should include. And what was interesting in that conversation was that they thought it was really broad. It included everything from ethical leadership and moral distress to the ethics of healthcare financing, to systems level ethics issues related to policymaking, to ethics related to organizational change initiatives, and a host of other things. So when we realized that the breadth of what people thought was organizational ethics was so wide, we realized that to some extent we needed to start at the beginning with our first presentation and talk about what does it look like in some kinds of organizations? And I will just say at the outset, I think both of our presenters would back me up in saying that they are not going to cover the entire gamut of what is organizational ethics or what does it look like in various organizations. This is a toe step. This is like we're barely sticking our toe in, but we wanted to get the conversation started. And so that's why that's why we wanted to hold this presentation. So let me bring you to who our actual presenters are and introduce them as you see them on the screen. First up, we have Anita Wagner, who is Associate Professor in the Division of, let me actually switch my little slide here. I'm not so good at this. There we go. I have Anita Wagner, who's Associate Professor in the Division of Health Policy and Insurance Research at the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. She serves as the Director of the Organizational Ethics Advisory Program of Point 32 Health, which is the parent company of Harvard Pilgrim Healthcare and Tufts Health Plan, two nonprofit healthcare insurers in the Eastern United States, and she's a member of the Harvard Ethics Leaders Group. With colleagues across the world, Dr. Wagner conducts empirical research generating evidence for answering challenging healthcare system questions. She also directs the Department of Population Medicine Center for Cancer Policy and Program Evaluation and the Harvard Medical School Fellowship in Health Policy Insurance Research. She's highly published and has performed important work to strengthen the capacity of professionals to design, implement, monitor, and evaluate medicine policy and programs in the context of expanding health insurance coverage. And our other co-presenter is Sue Reeves. She's Executive Vice President of the Dartmouth Hitchcock Medical Center and Chief Nursing Executive at the Dartmouth Hitchcock Medical System, Healthcare System. She's responsible for establishing and executing the Dartmouth Hitchcock Medical Center's short and long range objectives in the context of the healthcare plan, strategic plan, to ensure efficient, effective, and high quality patient care to meet the community needs of the service area. She possesses decades of knowledge and experience and has been a member of the Dartmouth Hitchcock community for more than 40 years. She's also a clinical professor in the Department of Community and Family Medicine at the Geisel School of Medicine at Dartmouth College. Her scholarship interests lie in the field of healthcare quality and patient safety, organizational ethics, and she actively participates in numerous local, regional, and national programs with this focus. And she serves on the board of directors for the New Hampshire Hospital Association. All right, so let's move to our first topic, which is the ease of organizational ethics. What is it? And so let me first ask our speakers, how do we think about defining organizational ethics so as to best apply it in your setting? And we can see, you know, the organizations from the chat, our members or the attendees here have ranged from nonprofits, for-profits, single institutions, multi-institutional systems, teaching and non-teaching institutions. And so would really like to hear sort of how do you define organizational ethics? So let me throw this to Anita first for her thoughts.
Thank you. Thank you, Melissa. And thank you so much for the kind introduction. Thank you for having me. And thanks to everybody who is listening in and contributing, I hope, in many ways with questions and contributions and suggestions and your own experiences. So just very briefly, when I think about organizational ethics, and as Melissa has mentioned, my context is that of a nonprofit health insurance organization. So not the clinical ethics, but nevertheless, I always sort of think about it adopting, I think, something that you, Melissa, probably have developed or at least co-developed, namely the iceberg slide in the VA system, in the integrated ethics system. And so I modify that in my thinking about the tip of the iceberg being the clinical ethics, the patient, all the value and moral and ethical questions that arise in individual patient and individual clinician and family member interactions. The next layer underneath the tip of the iceberg above the water, I think is, in my mind, is organizational ethics. And that concerns itself in my mind and in our practice in our institution with the policies and processes and structures of the organization and the values around those. And then the sort of the bulk of the iceberg in my mind is societal ethics. So it's all the issues that occur in society in a morally diverse, fast moving, ever changing society. And I think the organizational ethics has to maneuver both the tip of the iceberg and the bottom of the iceberg and make the right decisions at the right time, or support organizations in their structures, policies and processes to make the right decisions in their space, in the context of what comes to them, of what comes to us as an insurer, from the individual interactions and what happens in society. So let me stop here, and I can delve further into sort of the three aspects of the work that we do, but maybe at another time, a little bit later. Thank you.
Sue, what are your thoughts?
Thank you, Melissa. And again, it's delightful to be with everybody this afternoon. It's a little daunting, actually, for me to be in this group, as I really consider myself someone who is still very much a learner on the spectrum of organizational ethics. So to be presenting to people with this level of knowledge and experience, again, it's just a little daunting for me. But I do think that as someone who has had probably my introduction to ethics training in clinical ethics, like probably most of us have, and having taught biomedical ethics in a nursing school for several years, as I think about the definition of organizational ethics, it helps me to think about the focus of the activity. And there were some really excellent papers put out at the beginning of the pandemic, the COVID-19 pandemic, that really were focused, the Berlinger article, that were really focused on how does an organization think differently about its ethical responsibilities than the more primal provider relationship to an individual or to a patient. And I was intrigued to learn really that one needs to think about the organization's response and obligations that it has to its communities of interest. And in a healthcare organization, those communities of interest absolutely include patients and families, but they also include our staff. And we also have responsibilities and obligations to the communities that we're serving, and the state officials and the state organizations. And to be candid, as the leader of an academic medical center, my challenge is not to sit down and think what could constitute an organizational ethics issue in my everyday life, but more often it's what is not an organizational ethics issue in my everyday work. In the course of my day, I can probably almost routinely identify 2 or 3 organizational ethics challenges that I face as, again, I go about my everyday work. Why does that happen? As I thought about it, there's certainly the very predominant issue of justice. And as it relates to justice, really the allocation of scarce resources, that concept that nestles up inside the concept of justice. And, allocation of resources is something that we wrestle with every day. And if I think about our work during the pandemic, our first wave of the pandemic in my institution, we wrestled through allocation of technologies such as ventilators. In the second wave of the pandemic, we were wrestling with the issues of not having enough staff to actually keep enough critical care beds open. So how were we going to allocate critical care beds in my organization? Then came the vaccines, and they did not come out in great quantities at the beginning, so we had to wrestle through the issue of allocating those scarce resources to not only our staff, but also the individuals in our community. And, right now, as we're actually on this webinar today, we're wrestling with a shortage of contrast material to do different types of exams. And my organization is trying to come up with schema right now for which procedures, translated to which patients, will be able to have imaging that requires contrast, which are more important cases, more critical cases than others. So I mentioned some of these examples only to say, I think that certainly scarce allocation of resources is something that most leaders in healthcare organizations deal with. But everyday kinds of things also, bring up challenging organizational ethics issues for us. We're in the preparation of our fiscal 23 budget right now, and like most large academic medical centers, have been just dramatically impacted by the pandemic's activity, and are finding ourselves in the position of certainly not having enough resources to do what it is that we need to do. So making decisions about where we allocate these very scarce resources going into the future, again, is part of what I wake up thinking about and go to bed thinking about every day. And, just routine everyday issues such as bed availability and managing our limited capacity. One of the things that, again, I think my ability to step back and consider this question, and I've been thinking about this for a while now, has been what are the principles? If we're thinking about clinical ethics, we often talk about autonomy and beneficence and non-malfeasance and justice. But for organizational ethics, I think while those obviously are important, I think there's additional ones in organizational ethics that come into play. And I think, if I were to characterize what some of those might be, There's the issue of veracity or truth-telling, and if we pull that thread just a little bit further, it might be, what is our obligation around transparency? And it's transparency about our outcomes, transparency of data, and in many instances, perhaps even transparency about how decisions do get made in our organizations. Certainly fidelity comes up for me as an administrator, and that is, the promise keeping that I think is our responsibility to be there for people who need us, to those communities of interest. Obviously, beneficence is one that I think about a lot. Do good things as you're seeking to meet the healthcare needs of the communities of interest. One that I'm chewing on a little bit, it may be more important to me and maybe not Sentinel. I'll be curious what people think, is humility. I think is perhaps one of the concepts that we have to pull on a little bit that underpin organizational ethics, because it really is the quality or a state of being humble and, taking responsibility for the things you are responsible for, and also having gratitude. And then finally, respect. And that is obviously respecting the dignity of persons and property, diversity, and the laws and regulations that guide our organizations. So that's sort of what I've been thinking about in terms of a definition of organizational ethics. Melissa said it beautifully at the beginning. It means a lot of different things to a lot of different people, but I would say that's how I would approach the issue.
Thank you, Sue. Thank you, Anita. Let me throw to a couple of comments that were made and in the chat, and also encourage people to put up the poll. I did see that we put up the poll and I lost the results, but the results of the prior poll sort of indicated that people were sort of stepping into or had an interest in developing an organizational ethics committee, but weren't, we had a very small number of people who were actually sort of fully engaged in that. But a couple of comments that are in the chat that I thought were very interesting was thinking about the Iceberg model and really responding to your comment, Anita, about, in two of the comments, I think they hit in two different ways on that Iceberg model. One is the idea that maybe the Iceberg model hides the realities of what and how ethics negatively impacts healthcare, or if organizational ethics dominates in a particular component of ethics discourse. And I think we see that a lot. The resource allocation pieces tends to be what everybody thinks of as organizational ethics. And there's, of course, a whole range of things, in what Sue said. And then on the other thing is the concern that the pyramid is actually flipped, right? That we focus all on the clinical, it's sort of in some ways it can be interpreted that the organizational ethics is nice to have as an optional layer if you have the resources, rather than being that sort of central thing. And I'd love to hear your responses to those, sort of both of those comments.
Yeah, so thank you very much. So I'm not sure I completely understand the comment, and would love a little bit more from Donald Patoff on the negative impacts of ethics. But let me maybe talk a little bit more, also building on what Sue had said about the organizational ethics aspects within Point 32 Health, this insurer in 5 New England states of about 2.2 million members, nonprofit insurer in those states. And so all the things that you have mentioned are really ringing very true also in our context. And so I see the function of so for us in the context in which we work, and I don't by any means mean to suggest anything different from what Melissa had said, namely organizational ethics is evolving. It's much behind in terms of its evolution in all aspects, behind traditional clinical bioethics, and it's not the same in either definitions or implementation in different organizations. So the way the 3 pieces look like in Point 32 Health is that we have 3 objectives. One is to support the organization in thinking through and making explicit the value dimension of its day-to-day, as Sue mentioned, more often than not, challenging decisions that the organization leaders have to make on a daily basis. So doing internally supporting that decision making and making explicit that there are values components to those decisions. Secondly, to show to the outside world that we think carefully about the challenging value components of those decisions in the world in which we live. And then thirdly, to anticipate, given the changing environment, what the challenging questions and the challenging ethical and values aspects are that will come to us as healthcare and health systems and society change rapidly. And I think a key aspect of the function of organizational ethics in my organization is to actually allow for an expression or for an expression of the culture that and for a reaffirmation of a culture that has a mission to it, and that mission oftentimes is challenged in this margin mission balancing act that Sue alluded to. Scarce resources need to be prioritized, and what is the right prioritization? How do we do that? And when we make these decisions, what things are we prioritizing? What principles are we prioritizing? Whom are we prioritizing? And so that's this organizational culture function and affirmation is an important one. And then obviously then the question arises, so how do we do that? What is the vehicle? How do we operationalize these overall goal to support the organization and to show to the outside world that we care in these ways and along these three objectives? And so how would that be done? And I'm sure that would look differently in different organizations.
So let me twist this a little bit, both because of the poll, but also because of some of the comments that are being made in the chat, which is, sort of the poll says, what are the risks of conducting organizational ethics discussions? And people are starting to put those in. And I think even some of the first question was a little bit about the risks of even how do you construct it, how you think about that. In essence, how you define organizational ethics and the limits and the breadth of it is in and of itself a potential risk, right? Because you change how people understand it. So let me throw that, in a way to you, Sue, this concept of why does it matter, what we think about it, how we define it, or does it, especially from that leadership perspective?
Great question, Melissa. I think it does matter how we define it, because I do think short of at least some framing, as we just pointed out, there's probably nothing that doesn't fall into the category of being an ethical challenge, for organizations. I was, in case I was asked for examples, I was just writing some of the examples that since taking my position in the last couple of years, I've actually activated our organizational ethics committees for. And they've been, wide-ranging sorts of topics where one could say, is this really an issue for an organizational ethics committee? But it was, again, that's why I go back to clarity around organizational ethics and who the communities of interest are, and what are the kinds of concepts that organizations really need to be thinking about in terms of keeping their promise to those communities of interest. I hope that gets us to a more clear understanding of, the roles of these organizational ethics committees, how they differ from business ethics, how they differ from our clinical ethics committee. And I think with the increasing clarity, I think we'll actually see, my hope is we would see a broader adoption of this kind of a mechanism to be adjunctive to, again, daily work in terms of how we make some of the choices and decisions that we make.
Anita, what are your thoughts?
So let me comment on on one piece that I see here in the chat around the risks, and so I think I see a comment here as having to do with shooting the messenger or people not living up to expectations. I think, and also maybe coming back to another question, Melissa, that you had slated for later, namely the collaboration of organizational ethics with the C-suite organizational leadership. So, so what I've learned from my mentor in the apprenticeship with Jim Sabin, who co-founded more than 25 years ago what then was Harvard Pilgrim Healthcare, one of the two insurers now, actually even earlier, prior to another merger, co-founded Dr. Jim Sabin co-founded what is now the Point 32 Health Ethics Program, and the major premise of this program is that it is not looking over people's shoulders, and that it is actually serving the leadership of the organization in the sense that the leaders bring the questions that are to be addressed to the program. And so their support is crucial, and that may be different from clinical ethics, where clinical ethics can possibly operate in hospitals and has a long-standing history there, without necessarily C-suite endorsement or development in great detail. From the experience that Jim has shared with me over the 20 plus years that he has led this program, and the experience that I have in the last several years, is that the support of the CEO and the vice presidents of the organization is crucial. And so this program in Point 32 Health has been in existence much longer than any of the CEOs that over the course of the 27 plus years of its existence have served the organization. And so I think a risk for organizational ethics existence is that it be viewed as a program that is sort of a big brother overlooking decisions and binding people to whatever the recommendations may be that come out of deliberations. So very purposefully in our program, the recommendations are asked for by leadership and listened to, but they don't bind the organization.
Let me follow up on that with one of the questions that I had that came in the chat. And I'm gonna substantially shorten it, but I think that the speaker's thought is a good question. I'm interested in how the speakers think about organizational power as a unique dimension to consider in organizational ethics. And is the fact that the moral agent, the organization, is situated in the private sector and is itself often a corporate body, whether for-profit or not-for-profit, a distinguishing feature of organizational ethics. And let me throw that out, because in contrast with some of the things that are being said in the chat, which are talking about kind of how the clinical staff are brought in, distinguished either from clinical, organizational, business ethics, but also how the clinical staff get kind of, should we say, I'm going to put it in a different way than it was said, but kind of used in the processes of these analyses and organizational pieces. And I'm sorry if I took some of this out of context from the comment, but let me throw that out to both of you and see, what your thoughts are.
I'm quiet, Melissa, because I'm not sure I grasp the question as clearly as I should to be able to respond to it. I'm not sure about the concept of using clinical staff, that organizations are using clinical staff. So I might need a little bit more clarity about the intention of that comment.
Let me throw it to that the power dimension between leadership and the organization in that analysis of the organizational ethics challenges. And I think, Sue, you can sort of speak to that. We know we've definitely all been in a meeting, right, where the boss walks in and you were having an interesting, rich questioning kind of discussion, and then the boss walks in and that's it. You know, and then when you, of course, you're talking about ethics as the whole thing, you know, as the content of the question or content of the discussion, that has even a whole other level. So let me throw it at that point.
So again, one of the things that I said in the earlier piece was I'm chewing on this concept of humility, leader humility, as again one of the precursors, but also organizational humility, and the willingness to step back and understand that you know, yes, you may from a positional standpoint have power in an organization, but to imagine that you can hold all of the knowledge your organization needs you to hold to make the best decisions possible, there's a level of perhaps arrogance in that thinking that is concerning to me. So this notion of learning and humility is important. You know, one of the questions you asked us to think about is, you know, really what's the value of an organizational ethics committee? And, you know, the way I've described this, you know, when during the pandemic, when we were gathering to really think about our work to develop crisis standards of care, the phrase I've used in a couple of different settings is that I gave ourselves the gift of an organizational ethicist to be at the table with us. And I use that language very specifically because, again, Dr. Sabin's been mentioned a couple of times here, but in an article from 2016 that he wrote, he said that, you know, one of the things to appreciate is that what an organizational ethics committee brings is decision support. I happen to think, you know, we've heard the cliche, it's lonely at the top, and to imagine that any one individual in today's complex healthcare organizations is singularly responsible for a decision. I know I certainly appreciated having decisional support. Not anybody, you know, it wasn't a decision. These groups were not decision-making groups, things that I've really asked the organizational ethics committees to debate and deliberate about. It's really to help bring clarity and discernment to the issues to help us think better about things and come to a better decision. I think it is important that leaders be clear that input that we look for from advisory committees or organizational ethics committees is advisory. In the same way, again, I like the analogy that clinical ethics committees are giving advice to an attending clinician to help make the best decision possible. So again, I understand the power dynamic that you're talking about. I don't pretend that doesn't happen, that leaders think they know it all or think they're already acting tremendously ethically in everything they do. Of course, we like to believe that we're always acting ethically, but to really look at organizational ethics committees and resources and ethicists as gifts that you give yourself as a leader to make you a better leader, to make you a better decision maker, and help you with discernment on what I would simply just describe as some of the most daunting decisions I think I've ever been asked to make in more than 40 years in healthcare. So again, I think the value is tremendous if mostly around are we making the best decisions possible?
Anita, I'd like to get your perspective. I thought what was interesting in the poll, and you know, coming from your long experience, is that it was almost evenly split in the poll as to whether leaders should be involved in organizational ethics decisions or leaders should be informed about them, which you know, I thought that was interesting. And then this comment which says, you know, from the chat, in organizations, it's inevitable that people in different roles, leaders, their staff may see things differently. Leaders may feel staff are lazy, or staff see leaders are rapacious without justification, or perhaps there's ethical issues afoot. Organizational ethics programs can help improve communications where needed, help guide improved value-based decision-making where needed, often by not accepting a superficial story about what all leaders or staff are like. And another comment was, I think there are at times at risk of underappreciating the challenges that leaders face or perceive as they look at both present and future. The perceptions of ethical shortfalls may be legitimate and worth pursuing at the same time, perhaps tempered with, as Sue says, humility. Anita, what do you think about that, given your experience of that kind of, how is that role, where is that leadership, and how do you approach leadership with these issues?
So I think that there are, as Sue said, I think definitely in the organization of our ethics advisory group and ethics advisory program, the value is really in helping the leaders of the organization who have legitimate, challenging questions that they would like input on, to help to support them by helping elicit what is the ethical issue in this decision. Given the ethical issues, what is the right thing to do? Given that we think these are the right things to do, how do we do it in the correct way? How do we learn from what we have done in the past on these moral, ethical questions? And how do we look forward to the decisions we need to make? So these are the questions that we try to answer when a question is posed from usually one of the leaders of the organization to the ethics advisory group, which for Point 32 Health consists of internal employee colleagues in the organization and external people from all different disciplines and organizations. So the value for the leaders is there to gather information, to gather perspectives, to gather different inputs from very, hopefully, increasingly, hopefully more diverse perspectives. And that is the value. And it's not only the value to inform the leaders who have asked the questions, but also to allow for a broad-based communication amongst the people from inside the organization, for them to contribute to this deliberation, but also to see the fact that the leaders reach out for this input. And I think there is something to be said about validating some sort of vulnerability. If one asks for input from diverse stakeholders, internal and external, there is some sort of vulnerability, I think, that is portrayed on, we don't pretend to know all the answers. Yes, we might need to make different decisions, but at least the issues have been put out explicitly. And I think that goes into another aspect that I would like to highlight, or a term I would like to throw out for why, in response to your question, Melissa, earlier, why it is, I think, maybe even more than important than ever to consider these kinds of deliberations, and that's trustworthiness. We have to show ourselves as trustworthy. I don't like to say we have to build trust, because one can't build trust. Trust is something that's given. So we need to be trustworthy as an organization, trustworthy internally and trustworthy externally. And that then goes into all the principles, I think, Sue, you have so eloquently outlined for what you think on as an organizational leader you want to portray. And I see these organizational ethics deliberations in the way Point 32 facilitates them as one piece of showing that we try hard to be trustworthy in honestly deliberating on really challenging questions that give people sleepless nights.
This issue of trust is so essential. And the way I always think about it is, going back, early, right? What did we find out about informed consent? You were going to have a better informed consent conversation with a patient if you used a structured process rather than just what came off your head, right? And the research shows that. And yes, we can go too far with structured deliberation, but I think in the same way, like having structures and processes for open, transparent discussion, even if people disagree with the outcome, even if they fundamentally don't believe that the decision was the right decision, when those conversations are structured, present, and transparent, then staff can trust that the organization at least made the attempt. And as long as they believe those are an honest attempt, they can be supportive of it. And then they get all the other benefits, reduced moral distress and better engagement and lower turnout and better, lower burnout and all of those things. Let me throw it to Matt, and who has joined us from his last engagement, and see if he has any thoughts as well before.
Yeah, so thank you. And I apologize for having to join late today, just competing presentations. I wonder, Susan and Anita, the thing that strikes me about the conversation right now is how important it is that people like you are running these successful initiatives in organizational ethics. People like Jim Sabin, right, who brought a specific sort of set of character traits almost to the work. And what you're describing right now puts me in this sort of question frame of, is this work that requires a specific type of person who is capable of managing up and providing advice in a way that it is digestible and not alienating or threatening? And/or are there trainable things that you have learned over time about how to do that? And many people could become leaders in this arena, and there could be many more successful programs like yours, which are rare right now, but there could be many more if only we had a cadre of people who knew how to do this. And by the way, where would they get that training? What's the pathway that gets you to have the character traits that you guys have? Because you successfully navigated these minefields, but you presumably came to this minefield with some underlying, personality characteristics that allowed you to be successful. Because I don't think, I'm asking almost a rhetorical question. I don't think there is a training program out there right now. So maybe my question at the end of all that is, should there be?
Maybe I take thank you, Matt, and it's so wonderful to see you. And I know that you have been on the Point 32 ethics deliberation. So thank you for that long-standing support and extending it after Jim handed the baton over to me. So I really am grateful for that. So I, of course, I looked for training programs when Jim and I discussed this his transition, and much earlier actually, and no, I think I didn't find any. I am, of course, in the absolute luxurious position of having had many years of apprenticeship by the person who is, in my mind, embodying organizational ethics creation. I think it's more than it's a person, and I think those key skills can many of them can be learned, but it's also the organization. And there I'm reminded of something that Jim told me. I'm sorry, this is my dog, and I apologize.
Matt,
I understand the dog. It always happens. No worries.
Sorry, this is the first time in 2.5 years that it is that disturbing. So I apologize for this. So I think there is also an organizational mindset, and I'm reminded of efforts that Jim shared with me that he has over many years tried to share with other insurers the importance of creating a function that he has created at Point 32 Health, formerly Harvard Pilgrim Healthcare. And I spoke with him actually on Friday, and he said, you know, I have never succeeded with this. And he felt that this was due to the particular mindset of the organization in which we work, which is actually, from Jim's characteristics, it was easier for Point 32 Health compared to other insurers to embrace organizational ethics because the organization has emerged from clinician-led organizations. So the HMOs preceding the current organization were clinician-led health plans, HMOs. And in clinician environments, Jim tells me, he obviously himself being a psychiatrist, having practiced clinical psychiatry for a long time, the ethics is closer than in other organizations in a clinician mindset. So his sense was that the leap from clinical bioethics focused on individual patient-clinician family interactions around an individual patient to organizational ethics in hospitals is possibly easier, given the familiarity with ethics in those environments than in other organizations, in other business environments. And so other, in this case, would also be other insurers that don't have the history of Point 32 Health as clinician-led organizations. So I hope I did answer aspects of your question, Matt.
Let me twist it a little bit, because one of the things that's been commented on the chat is a couple of things. One is that you can have an incredibly ethical leader and have them be structurally caught within an unethical organization, which I think points to that sort of organizations that allow you to support you to express, you know, the ways that you can be an ethical leader. And then the other piece is that the comment in the chat is that some of the training in ethics is taking place in business schools and in healthcare management programs, but the worlds are often academically siloed from the clinical sphere. So you have this inability to have conversation, which I think actually often in my experience leads to a difficulty translating. You may even be talking about the same risk problem or the same ethics issue, and the language you're using is so different that the two sides don't even see the issue in the same way, can't understand it and unpack it. So let me throw that to the two of you for your thoughts.
Melissa, you're hitting on something that, again, I've been thinking a lot about, and it is, to respond to Matt's question, I think the real need for a core curriculum that can transcend the different types of training programs, so that there is a commonality in terms of how we're training our professionals who will be leading these organizations. It is hard to separate, what is leadership development training or leader training? What are the more academic programs that train MBAs and Masters in Health Administration, et cetera. But to get to Melissa's point, they may be doing it a little bit differently or having a little bit of a different foci in each of these silos, if you will. So the need for a core curriculum, I think, is one that would be very welcome, so that, much in the way when, and I'm going to hearken to my days teaching biomedical ethics, there's almost a standard by which you take students through teaching them about biomedical ethics, and you learn about the core principles that I mentioned, and you actually learn an ethical decision-making framework process for really interrogating ethical issues. So I would say we need the same for organizational ethics. I think it is a shortcoming that we have right now. And probably in response to Matt, again, one of the additional things I would say is we may have individuals who have the right predisposition to bring humility and to bring a learning approach to how they're leading. What they may lack are structures to actually help them do this work. And so in my mind, it's a little bit of, core curriculum so that we speak the same language, recognize structures, sort of how-to toolkits for people who are asking, how do I do this in my organization? What's necessary from structural perspectives? How do I codify some of these things in policies? How do I make job descriptions for the leaders of these things, et cetera? So it's a little bit bringing the same structure to the organizational ethics world that we have already brought to the clinical ethics world. It's really now time to sort of do the next big leap in organizational ethiks.
So let me switch our topic, because I do think this is that kind of, the important piece, and it's two ways. I know that I know that our membership is very, very interested. The OEAG membership is very interested in how you build these programs, right? And I think that's, but part of that is, again, even in that issue of the sort of the linkages between clinical, organizational, business, ethics, and thinking about how do you go from this concept, right, that's coming from the business side of, leaders create the culture and leaders are supposed to be ethical in and of themselves. But we know that without structures that live on when those leaders switch and, that create that and embed those processes. And I think that the program that Jim started and that Anita now runs is such an exemplar of that. Yes. By forcing those leaders to at least contend with it. They can't get rid of it right off the bat. So how do we go about that? And especially as I would relate to, I know there's a lot of people on this group who don't have that already, but would like to. So how do we move to that, especially when you're even talking about what is business ethics, what's clinical ethics, should these spheres connect? How do you bridge all those?
So maybe, Melissa, would it help if I just shared, for those who don't know, what the key aspect of the organizational ethics program that Jim created many years ago is, and how it functions? Because I think it does serve it serves in some ways the leaders in a pretty structured way. So maybe I briefly explain how that works, and I think there's many more aspects that could go into an organizational ethics program, but here is how what we do and what Jim has created and what has been maintained since 1996 essentially. And so what the mainstay is a quarterly ethics advisory group deliberation that we host, and that is built around topics that leaders of the organization bring to me, in this case formerly to Jim, as challenging topics on which they would like to have internal and external input. I then develop these topics in collaboration with one or two of the leaders who serve as customers of the deliberation. And we frame together the ethical questions on which a diverse group of members, now up to 100 in recent conversations, because we've moved the conversations from an in-person meeting to Zoom, so can provide input. So we elaborate on the topic. I write a background document that lays out what the issues are in general and from an insurer's perspective, and also include how we have, if we have the topic, addressed the topic in past quarterly deliberations, of which we have a database of some 140, how we have addressed the issue in the past, what the reflections were in the past, and then we frame this in a document that goes out to everybody inside the organization and to a mailing list that now comprises some 500 addresses, and the people are invited to join the conversation. And as I said, since the pandemic, this has been on Zoom. And if there is a silver lining to the pandemic, I think the fact that we have been forced to move these deliberations online has been a benefit in many ways. It has also had its challenges, but it has been a benefit. We host in these 90-minute conversations where the organization leaders set the stage for what they would like to get out of the conversation. I facilitate the discussions. The new CEO of Point 32 Health, who started in September, has not missed a single one of those conversations. And after the 90-minute conversation, I summarize the conversation in a report that again goes out to the entire mailing list and anybody who is interested in it. And I see Kelsey is on here. Kelsey has been a key co-moderator of these conversations and a key supporter and help in facilitating these discussions. The feedback on the conversations has been tremendous from inside, thanks to of colleagues in the organization. Thank you for openly discussing these topics, to outside customers of the organization. For an insurer, that's employers, that's brokers, that's members, it's the general public, it's government institutions. All of those can participate and are appreciative of the output. Let me stop here, and I'm obviously happy to talk about the topics we have addressed. I think I saw a question there, but let me stop at this point.
Sue, you want to comment?
I was thinking a little bit about, again, how well developed, in listening to Anita, how well developed a program that is. And I'm relieved to know that it's been 25 years in the making, because these things do take time. I was trying to think a little bit about how leaders engage with their organizational ethics committees. And I think you may have said, Melissa, as we were talking about this session, that we have groups that do not have organizational ethics committees embedded in their organization yet. And we have, in contrast, this very well-developed program that Anita's leading. And, you know, I've been thinking about this a little bit along a spectrum of development. And as I think about the program here at Dartmouth Hitchcock Medical Center, I would say that, again, when I started my work in this role, and I thought about what did the Organizational Ethics Committee see its role as, really it was, they had a very clear and identified role in conflict of interest management. So there was a process in the organization to manage conflict of interest. They also were the reviewers and authors of the Code of Ethical Conduct for the organization, but they really had a more limited view of the role in terms of the types of issues that I wanted to refer to them. And I see there's a question in the chat: what kind of issues do the organizational ethics committees review? And things, again, that I convened the committee to deliberate about. There were several of them during the height of the pandemic, you know, in terms of reviewing the crisis standards of care we were developing, but also I've sent questions to them that have to do with our research mission. And you know, one of the situations was we had a research trial coming to an end. It involved the implantation of a deep brain stimulator, and you know, the question was, what do you do at the end of a trial if it's working and the trial is done? And so we had to actually talk as a group about, you know, the various obligations of the organization, the research organization, the principal investigators, et cetera, in terms of, again, promise keeping with patients. We had a couple of instances, and I won't get the names of the medication right, so pardon me about this, but there were medications in very short supply but they could be used for both individuals who were in these cytokine storms as, late stage in their COVID experience, or as a preemptive management strategies for patients undergoing a highly specialized bone marrow transplant procedure. And so there we had you've only got so many doses of this particular medication. Which patient populations would really we deal with in terms of allocating those medications to them? And then finally, we had an individual, this made the national news, but we had a patient who was being treated for COVID illness in one of our small outlying hospitals in New Hampshire, and the spouse of that person was demanding all of the unconventional treatment interventions such as ivermectin and other types of things, which the healthcare organization was not giving. And what happened is the spouse went on the national news and convened a whole bunch of people to support her in her stance, and they began sort of calling this small 25-bed hospital being threatening to the senior officers, et cetera, et cetera. There were bomb threats at the hospital. And in the midst of this, the question came up, what would happen if the patient required transfer to the academic medical center? And the question that came before us was, would we put our staff at that same risk in order to take care of that patient who might need a higher level of care? And so there the question was, again, whose needs would prevail, the needs to keep your staff safe versus the needs of a patient for advanced treatment. So that's an answer to the kinds of questions that, again, we've been trying to have feed more to our organizational ethics committee to, again, provide some better discernment about how do we think about these things, better decision support for those individuals who had to make those decisions. But I would not characterize where our group is in the same way that Anita describes her group is. I think we've got a lot more development to do to get them from sort of, we manage conflict of interest in the organization, which is a business ethics issue, to really the more full scope of really what does a healthcare organizational ethics committee really need to wrestle with? What do they need to be capable of talking about?
Anita, did you want to respond to that?
Yeah, I just wanted to add to it other examples of topics that have come before the Ethics Advisory Group of Point 32 Health. Some of them very similar to what Sue, you have mentioned, sort of the margin mission resource allocation issue, because as an insurer, the organization has to wisely steward the resources of its members. So by way of examples, the most recent conversation we had was, what is the role of a health insurer in facilitating gender affirming care? So here again, we are sort of in between the individual patient impacts of policies the health plan has in the societal context in which it operates. So that was the most recent deliberation we had. The one before dealt with the responsibilities and the levers of the organization in the decision making around paying for highly expensive drugs that have limited evidence of benefit, prompted by the Aduhelm approval, the Alzheimer's drug approval of FDA. And obviously we have many such medicines. So it was a bigger picture, not just focus on the Alzheimer's drug approval, but in general, what are the responsibilities of an insurer who needs to wisely steward funds when there are demands for and regulatory approval of pharmaceuticals that most people consider not providing necessarily the benefit it is said to provide. Another one, very importantly, the conversation we recently had are, how does a health insurer engage ethically, trustworthily in partnership with community organizations so as to undo unjust injustices in society, long-standing structural injustices, racism, and other isms, which the insurer is not necessarily having lived experience. The leadership of the insurance may or may not have lived experience in some of these structural injustices, but needs to, in our mission, we are responsible for the health, of course, of the members, but also of the communities we serve, as per the definition of our CEO, going much beyond the insured members of the organization to the communities in which we operate. And so in those communities, the insurance leadership for many of the members will lack lived experience and insight. So it needs to partner with people who have lived experience, who have the trustworthiness in those communities. And so how do we partner ethically with community organizations to do the work that we see our responsibility to be, to care for the communities we serve? In COVID, when vaccines were distributed, but clearly not distributed equitably, we raised the question of what is the insurer's responsibility to remedy inequities in vaccinations? And so a program actually followed that. There is a lot of questions around algorithms we use in healthcare. Insurers routinely use mandated, standardized algorithms for care management. And the ethics deliberation that we hosted on what is our responsibility to interrogate those algorithms and then do things with the answers actually led to a whole sequence of actions on the part of medical informatics in the organization. So these are some of the examples that the leaders brought, topics that the leaders brought to the ethics advisory group deliberations for input, and that then were resulted in suggestions. Again, none of which are binding in point 32 health.
Let me throw out a question there, because I mean, what's amazing about that sort of length, and I think in both of the lived experience becomes in and of itself a data point of value, indicating the value of the committee, because those are tough things that the leaders are experiencing, right? And but so often when you're starting a new program and everything is so data driven, as this was brought up in the chat, when you're going to go into, you want to build a program, you want to start up a program like this, the first question they have is, well, what proof do you have it works? What proof do you have that training your leaders in these ethical principles has any value at all on the organizational culture? That's one set of measures. Then there's also the organizational ethics committee. If we're going to start one up, well, how do we measure to make sure that it has value? We have a long conversation about whether clinical ethics committees have value in a set of measures. But I don't think that we have a set of those for organizational ethics committees yet. So I throw it almost as a thinking, and I throw it even to you, Matt, to all three of you, sort of what are some of the things, if you're starting that up in the absence of good measures, how should we be thinking about those? Because the lived experience, you're not going to have going into it until you've seen a few of those where it was actually useful.
Yeah, I agree. As we were just having this chat conversation on the sidebar about what are the impacts? What are the potential outcomes beyond, I feel better about the decision I had to make, which was a challenging decision. And that narrative description of the experience is part of what Mary brings to her work, right? Is many, many stories. And a whole bunch of stories in aggregate starts to look at least like qualitative research on outcomes, if not, empirical data on, staff turnover is better in organizations, or, lower in organizations that have this kind of an environment. And here's how we measure this kind of environment. I think it would be lovely if we had, 60 organizations out there that had an organizational ethics infrastructure like at, Point 23 Health, but we don't. So it's going to be a challenge to get some of the types of outcomes that we would really ideally like. On the other hand, I can't count the number of things we do in, medicine, starting with medical education and all the way through to medical practice, where we don't have solid data that, you must dissect a corpse before you become a doctor or you will be a worse doctor, right? And we do all kinds of things because people say, that was a really valuable experience. I got a lot out of it. Everyone else should have that experience too. So, stories and zeitgeists arise around these things. And, we don't insist on data for everything. We insist on data for things that we're reluctant to implement. So just bearing that in mind, I still, of course, I believe in data. I think we ought to have data on this. And I would love it if we had 30 or 40 programs where we could actually say, let's see if we can implement a few things in this program and a few things in this other one and see whether it changes staff turnover or, results on the patient safety survey or, right? I mean, there are a lot of ways in which you could envision measuring the impact of having some form of organizational ethics infrastructure. But I think we would need more than one or two organizations to be able to do that.
If I may just endorse, Matt, what you said, the stories, I think this is really what this program allows us. It allows us to build, to see, to live, to see, to exemplify stories of who we are, what the values are that we as an organization espouse. And, in this case, we espouse the value of talking openly and dedicating 90 minutes every 3 months to a large number of organizational leaders and colleagues, plus all the outside experts like yourself, Matt, to join into a hard conversation. That's a value. That's a value of the organizational culture that we demonstrate. And then I think the stories around that are a testimony, I think, to who we are. And I think that has value. It can't be quantified in ROI, but it is a value on its own, I would argue.
Matt, I think the thing that I'm thinking about is sort of the last step in any type of ethical decision-making process is that part that talks about evaluating the decision. And so many of our organizational ethics issues don't have short evaluation horizons. They may have longer evaluation horizons, but sort of as you're thinking, you're doing an organizational ethics consultation. One of the questions that I think is important as you're thinking about the process of evaluation, how did this go? Did this, have the intended consequence or the intended desire we had hoped, is to ask, how will we know the impact of this decision and if it was a good one or not? And I think people might be able to suggest different ways of knowing for how we evaluate the quality of the decision that we arrived at. That would be one thing, is again always evaluating decisions that we come to, and then checking back to see if we actually hit the mark in terms of what we thought was going to happen. I would also say that probably the other way to evaluate is your organizational ethics committee bringing value to your organization. It would be, as you go through the process of consultation, and you do a couple of cases that feel similar, much in the way in clinical ethics, you can often find places that if we educate better, if we change processes better, you can actually prevent the dilemma or the challenge from coming up in the first place. So that whole notion of preventive ethics, are you using what you're learning to actually see if you can't possibly try and change this particular challenge for the future. So first thing, I think it's always evaluating and having the opportunity to ask people, how will we know if we made the right decision? What will that look like? And then secondly, using that information to try and, again, focus a little bit, to the extent it's possible, on preventive ethics, so we don't find ourselves in the soup on the same issues over and over and over.
So let me, I'm going to post my last couple of, as I try to draw this together. I would love to see, there's a question in the Q&A, which was, you know, does this have to become, this conversation about organizational, does it have to be from within? One of the question is, do speakers think that organizational ethics can occur successfully through engagement of a consultant external to the organization, or do we have to go with an internal program? You know, what's the value of the internal program versus that external consultant?
So, Melissa, you're asking all of us?
I'm asking whoever would like to comment on it. I think, you know, I think so many of us coming from the clinical, from the outside, would love to be able to be supportive of organizations. We know they're not going to hire an external consultant 100% time. But can that even do that? Does it work that way? Or do you really have to home grow this in your culture so tied in? I think is in a way the question. Sue, you're shaking your head.
I don't want to speak, though, if Anita was going to say something.
No, go ahead. I mean, I have only one example, and it is sort of a little bit inside and outside is where we are. But I was trying to imagine myself, the organization hiring somebody completely outside of the organization, and I could see that as challenging. I don't really quite know how that would work. I just wanted to say that I'm within the organization, but I'm also a little bit outside, because the organization that is my primary home is the Harvard Pilgrim Healthcare Institute, which is the academic arm of the insurer, affiliated with the medical school, but also affiliated with the insurer. So it has the benefit of inside and outside.
My response, Melissa, was I was shaking my head, because I do think that probably one of the most important things to get started is to have a credible subject matter expert in organizational ethics, or ethics in general. I have seen in a couple of different circumstances these kinds of processes done not well, and they're, you know, homegrown and again, incredibly well-intentioned people. It's exciting to oftentimes to be involved in ethical discussions, but what I have found is, in the absence of any formal training or subject matter expert facilitation, those discussions often revolve around what people think according to their own moral compass, versus any kind of, you know, sort of organized process to think through a problem. So I do think, to the extent that subject matter experts can be imported into an organization, particularly for training and facilitation, it's incredibly useful. But you do that in concert with, again, the coalition of the willing on the inside who have an interest, but it's very, very important to have them well facilitated and then ultimately trained to do the work that we're asking them to do.
Let me ask Matt if you have any thoughts about that. Matt, you have to unmute yourself.
It would not be a Zoom meeting if I did not say at least one sentence while on mute. No, I was reflecting in the chat here actually on this question of what you might actually think of as, in ethics, we talk sometimes about casuistry as a method of ethical analysis, right? Case-based, recognizing similarities and differences between different cases, and the potential value of someone like Anita or Susan, who have been through multiple cases over several years. They really bring this fund of knowledge to the table about how similar cases have been resolved in the past, and a capacity to say, well, this is how we resolved it before. What are the differences between that old case and this contemporary case? Is this one that looks so similar that we can just patch it on and say, you know, that we know what to do here? Maybe this didn't even need to come to our ethics committee anymore because our organization has managed this before and we now have a policy, right? Or is this different in salient ways and is leading us to apply in a different way? So I think Vicky had recommended the development of a casebook, which I think would be incredibly valuable. And it would be valuable whether you were doing a homegrown ethics committee or whether you were someone trying to start a small business doing organizational ethics consultations. The challenge with the latter, I think, from what I've heard so far is just, is there a market for an organizational ethics consultant? And I honestly don't know the answer to that. I think there are people, making a go of it. But it feels like this issue, all the way back to the earlier conversation about trust and trustworthiness, so much of what might cause an organizational leader to say, I would value having an organizational ethics committee might derive from them saying, I really value my conversations with Anita, and I want her to run my organizational ethics committee. So it gets a little back to my earlier comment about to what extent is this relational and personal characteristics versus something that can be, that has growth potential as a business, because you can become really well known as being a valuable partner in making difficult ethical decisions for hospitals all over the country or health systems, all over the country. And I think the latter is going to be challenging. Even if someone like Jim Sabin were to be, the person who started it, I think it would be challenging to build that business.
It is all about personal relationships, let me tell you. All right, so in our last 3 minutes, let me do a couple of things. First of all, say thank you very much to all of our speakers for their valuable insights. I think the chat indicates that people have been really, really appreciative of the conversation. I'd also just like to throw up a great and huge thank you to the members of the OEAG committee who helped to think through, pull together this panel. Anita was on that, but we had a number of other individuals, many of whom were on this call, but many who were not, who really helped us to kind of hone our first focus for the meeting. And then I'd also like to put a huge thank you also to the staff at CU Boulder, at the medical school, at Matt's shop, for all the tech support. They have been fabulous in helping me get this off the ground. So I thank you and bow to them. Much appreciated. Let me also put out a call as people are hanging up rapidly. Matt and I roll off as OEAG leadership in November. November is our last, and we will be kicked out by ASBH. So if you think that this group is valuable, you would like to continue efforts, we need new chair or co-chairs for the OEAG starting in January. We will, of course, send out a note about that. But in the meantime, please put on your thinking caps, and we would love to look for new speakers so that they can join us in November and hand that off for leadership. So again, thank you so much to Sue, to Anita, to Matt, to everyone for your fabulous presentations. We really appreciated the conversation. And with that, we cede you all back to your day. Thank you so much, everyone.
Thank you, Melissa.